Welcome everyone. This is our morning's 45-minute breakout session, coordination of care. My name is Michelle Smith and I'm I'm with the BC support unit for the Interior Center. So this session uses Zoom meetings, and so there won't have the Q&A piece in it, but please do use the chat. It's helpful if you can direct the question to whatever presenter it is, and then they can respond. We can also exchange addresses or messages because, of course, it is a tight presentation. Everyone only gets 15 minutes, and you can follow up with them afterwards. Entities can pop in and out of the session, so you may see a bit of that. And I think if that's okay, we can move to our first presentation. Can a patient family-oriented discharge process improve the patient and provider experience of discharge from hospital? And they can share their screen. It might take them a second to do that.
Okay, ready to go? Sorry. Should go? Yes. Yeah. Hi, I'm Christine Walsworth, and along with Aggie Black and Megan McLeod, we are thrilled to be presenting at the 2020 Putting Patients First virtual conference. We acknowledge with gratitude that we work and live on the traditional territory of the Coast Salish peoples. So piloting PODS at Providence Healthcare, it was the introduction of a patient and family-oriented transition bundle, including the patient-oriented discharge summary, or PODS form. It was to improve patient and caregiver preparedness for discharge and confidence in the discharge process. It took place in 2 25-bed medical units at St. Paul's Hospital from May 2019 to May 2020. This project engaged patients, caregivers, and families as partners for better patient outcomes and transforming the patient role to that of a proactive partner. Both Kimberly Strain and myself are members of the Patient Voices Network, and we both endorse this project. We participated in all meetings and CFHI webinars. I also spoke directly to nurses on the unit, and I participate in presentations. So this is a photo of my late husband, Bill, and me, for whom I was his primary caregiver. My experience with poor transitions stems from caregiving my late husband, who had dementia along with a host of other comorbidities and some major surgeries. I believe that patients will feel supported and encouraged at the time of discharge if they are involved in a workable plan like PODS ahead of the discharge. I will share with you an example where PODS would have helped. I picked my husband up after a major surgery and was handed a list of allied health service workers and given verbal instructions that the people who were ticked on the list should be contacting me within 24 to 48 hours. And if they didn't, I should contact them. It was hard to absorb this information at a stressful time. Also, receiving his medication list ahead of the discharge would have helped so that I could have the pharmacy blister pack them. With PODS, some of the appointments would have been made ahead of the discharge or written down for me, and I could have focused on a discussion with the hospital discharge staff about the who, why, and when I should make the contacts. PODS would have also provided the medication information. Again, one less thing to think about while I scrambled to replace the home care support that had been cancelled while he was in the hospital. So from a patient caregiver point of view, it makes sense to use PODS because it's a systematic way for patients, caregivers, and staff to ensure that the patient discharge is most successful, and that leads to better outcomes for patients. Over to Aggie.
Thank you, Christine. Christine has sort of set the stage for us about why, from a personal point of view, this is an important project. So for any of us who have accompanied family members during discharge from hospital or have been the patient being discharged ourselves, reminded of why on a personal level this is such an important topic. Additionally, what the literature tells us is that an effective transition from hospital to either home or a community setting it has an important influence on patient safety and the overall care experience. When patients don't have confidence or good understanding of what to expect at home, that can lead to unnecessary hospital readmissions. We also know patients and families need support at the time of discharge from acute care. And for our personal hospital, we know that our most recent patient experience survey results showed that on the units where we implemented this project, only 55% of patients surveyed said they felt adequately prepared at the time of discharge. So clearly we knew we had some work to do. This is a photo of our team. So as you can see, we're large. We were diverse in terms of where we work in the hospital. So we included co-leaders, Suzanne Nixon, who's a clinical nurse specialist, myself, director of research, Megan McLeod, our performance improvement consultant and evaluation lead. Additionally, we had representation from unit level leaders, both the clinical nurse leaders, the nurse educator, the patient care manager, and their support really was essential in helping us understand the reality of what a discharge looks like on this unit. We also had clinical nurse specialists. As Christine said, we had 2 patient family partners and we had some allied health team members. So the bundle that we implemented had 4 components. So it had the use of a PODS form, which is patient-oriented discharge summary. And I'll show you a closer up photo of the PODS form. But it's important to note that it was co-designed by patients and families. So it does not look like a typical medical form. We also asked the nurses and social workers to use teach-back methodology when they reviewed discharge with patients and families. We wanted involvement of family caregivers who were present at the time of discharge. And we implemented for a 2-month period a follow-up contact phone call with patients who had been discharged. So this is what PODS form looks like. And when we first brought this form to our forms committee, they said, oh, no, you can't have those icons and you can't have so much black space. And the patient family partner said, no, this form is for us. This isn't meant to look like a typical hospital form. So with their support, we really kept this the way it had been co-designed by patients and families. I can't say enough how important it was to us to have support and data from the BC Patient-Centered Measurement Group. So this is the group that does all the patient experience surveys across 13 sectors in BC. They've got 17 years of data and experience. They're able to link their data with clinical and administrative data sets to help put it in context. There's close to real-time tracking, so you can go onto their website for your health authority and get almost real-time numbers on patient satisfaction surveys. And they're an incredible support to local quality improvement projects like ours. So our evaluation, which Megan is going to walk you through, came from basically these 3 categories of data. We looked at the patient and caregiver perspective. So that was data, as I said, that we got from the Provincial Patient Experience Survey and from the PODS follow-up phone calls, where patients were asked, if you received this form, the form was then described to them, was it useful to you? From the provider perspective, we asked providers on the unit how they felt about the discharge process before PODS, and then we asked them at 2 times close to implementation and then a little bit later. And then we had decision support look up the readmission rate to those 2 units to see whether PODS had had any impact on that metric. And I think I'm going to turn it over to Megan here. Thank you.
Thank you very much. I'm delighted to be here today to share with you what we discovered in this work. And we'll start by saying it's been a privilege to be involved with this team and also to present here today. So, right, we're talking about what we discovered. Perhaps a great finding to start with is that the patients find PODS helpful. So we started off doing chart audits early in the process, and then later with the patient experience data from the provincial survey, we know that around 60% of our patients actually receive PODS, the PODS form at discharge. And when we limit that to those who can comment about the PODS, so having excluded those who don't remember getting it, didn't receive it, or can't comment or prefer not to comment, 87% of those, which was 142 we were looking at, 87% said that they found it at least partly helpful. And that's the green line in the center. Sorry, the blue line at the top gives you how many found it at least partly helpful. So you can see towards the end, we were hitting near 100% at different times. And if we limit that to those who said it was quite a bit or completely helpful, we're still seeing 65%, bouncing up and down a little bit with the line in the green that you can see, but encouraging that patients are finding it helpful. And then some of the comments that support that are that it's useful because it lists who to see for follow-up, also what to continue or not regarding prescriptions, and that everything was clear. One patient did say that they didn't really refer to it as there wasn't much to do and the follow-up was expected, but yes, it was still good to have it. Another said that it's straightforward, made sense, is helpful. And this comment at the bottom, I think, is really important to look at. The form is really good. It had good questions about what to do at home. It gave a reminder about what was done and what to do. After my stroke, paperwork sends me into a tailspin, so the form was really helpful. And thinking about how patients sometimes leave hospital worried, possibly distracted, maybe even still on pain medications, possibly less able to take in the information that's being shared with them at that time. Being able to take something home with them is really helpful. During the follow-up call pilot, for 2 months, we decided that we would phone to see how patients are doing and to clarify any information that was on the PODS form. So we reached out to 42 patients who had received PODS at discharge. We actually were able to reach 29, so 24 patients and 5 family members. And overwhelmingly, the message back was thank you. Thank you for calling and thank you for the care that you provided. And so we were hearing things like, thank you for ringing and making inquiries, what wonderful service. Another positive experience with the healthcare system, thanks for the call, really appreciate it. This is the first time. Thank you for checking in on me. And being able to feed that back to the care team was really meaningful for them. And one comment in particular speaks to the values of Providence Healthcare and how we care for some of our most vulnerable patients, and being able to share that with the team was wonderful. I'm doing really well, everything is good, I'm really happy. You treated my pain and figured out what was wrong with me. Thank you so much, thank you for the call. You can also see that discharge is a surprise, and that does indeed speak to some of the complexity of patient flow. I'm happy to talk about that offline. So when we talk to our providers, we hear that they believe that PODS improve both their confidence in the discharge for the patients as well as their own effectiveness. So in the second survey that we did more recently, having launched right basically as the pandemic began, but still lucky to get 45 responses, from 57%, we heard that they were more confident that patients and their caregivers were adequately prepared for discharge. And on top of that, nearly half of them shared that PODS helps them to be more effective in their job. And so really happy to see that the providers are finding value in this form, that the patients do as well. And overall, looking at the provincial patient experience data, we see that for the unit as a whole, that where the PODS is implemented as a pilot, 79% of the patients feel quite a bit or completely prepared. They answered quite a bit or completely to the question about being adequately prepared for discharge. And this is up dramatically from a low of 38 to a high of 62 in response to similar questions on previous surveys. We also saw in these units that more patients are reporting the top 2 scores when asked to rate their overall hospital experience. So sitting now at 60% when it was 50% in the last provincial survey. So really speaking to the benefit of PODS beyond the overall benefit of PODS for the patients who receive it. We also looked at the avoidable hospital readmissions, and other hospitals throughout Canada have seen a dramatic improvement in this. Our data is slightly less convincing, but we are cautiously optimistic that we do see a small decrease, particularly in the 50 to 59 age group following PODS implementation. So we'll continue to look at this, considering, of course, all the factors that contribute to hospital readmissions. So from all of this work, 3 main recommendations have surfaced. First, that PODS continue to be the primary discharge document on the unit where it's been implemented, along with the teach-back principles and involving family caregivers when possible. Also, that PODS spread to other units, and three units are currently planning this, and we have a spread package that supports the adaptation and implementation for the context of the unit. And also that the follow-up phone calls continue and begin when possible. So We've seen from this pilot that the resources required are less than one would think initially, and that the patients and families really appreciate it, and the staff also really appreciate hearing back from them. And so I will say thanks again to the Canadian Foundation for Healthcare Improvement for the funding and the support through the Bridge to Home Collaborative. They also offer many resources if you'd like to investigate this more. And we also welcome questions that you may have. And on behalf of the team, I thank you for joining us today.
Thank you. Do you have any quick questions, or we can move to the next presenters? Just put them in the box, in the chat box if you have any for now, and we can move to Andrea.
Hi, Michelle. It's Wendy Petillion. I just have one quick question. Will this
Sure.
work be shared with other hospitals? So they just shared that they're now spreading and scaling it through different units at St. Paul, but will it also be shared with other hospitals? Because this is wonderful work. Thank you.
Thank you for that comment. We have shared this at several conferences, and would love to hear from you what venues you think we should also endeavor to offer this information. Please feel free to reach out.
Great. Andrew, would you like to share your screen?
Good thing. And thank you so much for that. That was really wonderful. I'm gonna turn my video off and pull this up. Okay. So just a big thank you all again for attending this session today. I want to share with you some information that I've been working on, and the title of this talk today is Coming of Age as a Pathway Towards Wellness for Urban Indigenous Youth in Care. And I'd like you to just be open to thinking about why coming of age can be a very positive intervention for coordinating positive care plans for youth. So first of all, I'd like to acknowledge respectfully that I'm speaking to you from Treaty 7 territory today in Southern Alberta. And for today, I am going to start with some introductions, just share a little bit about myself so that you know where I'm coming from, and also about this project. And then I'd like to get into these three main questions. So first of all, what is coming of age? Why is reconnecting to coming of age so important? And then as care providers, how can we help? And then we'll round this out with some time where you can share your thoughts on what you've learned or ask some questions if you have any of those. So here I am, and these are my dogs. And this is me at Mount Yamnuska and in the foothills of the Canadian Rockies and not far from where I grew up. I was born a Treaty 7 person and raised with the culture of my Chinese and British ancestors. I started my career actually as a hydrogeologist. I was working with groundwater resources, and first that was in Calgary, then later in Nanaimo. But I was finding that over time, the professional framework that I was working in didn't really have a broad enough, oh, pardon me here. The framework that I was working in didn't have a broad enough definition of health or health impacts to really capture the complex ways that the work we were doing was affecting people. And so I followed this sort of ethical itch, and it led me to the Social Dimensions of Health program at the University of Victoria. And this is where I'm completing my doctoral studies. So it was also during this time that I was invited to do work around developing culturally appropriate coming of age resources with an urban Indigenous child welfare agency, and that's surrounded by Cedar. So now before I launch in here to the main part of the talk, I'd really like to acknowledge that all of the project work was done in a community-led partnership, and all of our work occurred in Lekwungen territory. I have been given permission by one of our project's knowledge holders to share this acknowledgement here. This is in Lekwungen. And I've also been given permission by our project partners to share this work with you today. It's really important then to give thanks to the youth and to Surrounded by Cedar, all of their knowledge keepers, community members, and the staff that helped guide our work in a good way. Also to the friends and family that supported this along the way. It's really important to recognize that this was a really big community effort. And then of course to our funders, this was funded by a Shirk Reconciliation Grant, an Island Health Collaborative Grant, and we also had in-kind and financial support from the University of Victoria. I'd also like to just to share gratefully that I've received support from the Island Center Patient-Oriented Research Fellowship, and this is supported by the BC Support Unit. Okay, so we'll start just by talking what is coming of age. And I like to use this next series of pictures because it really exemplifies one of the fundamental pieces of what coming of age is, and that's passing knowledge. Okay, so coming of age, this is the transition period from childhood to adulthood. It involves preparation, learning the skills that you might need to survive. And there's this essential piece of intergenerational knowledge transfer. So now, during adolescence, the transitional stage, the coming of age, this has been called betwixt and between. And this is where young ones are pushed out of the comforts of childhood into the precarity of developing their own identity. And this cross-cultural and cross-species phenomenon really reflects the importance of guidance during this time of identity formation because it lays the foundation for the future stages of one's life. And that's adulthood, parenthood, elderhood. But now, when we add this contextual piece of a culturally centered coming of age, what does that mean? So I like to first reflect on what culture is. And I like this definition here. And McIver, Napoleon, and Dickey, this is in one of their papers, they suggest that culture encompasses systems of beliefs, values, customs, and traditions that are transmitted from generation to generation through teachings, ecological knowledge, and time-honored land-based practices. So from this, we can extend this to say that a culturally centered coming of age is one that aligns with the ancestral beliefs, values, customs, and traditions of an individual, a family, or community. But then now, how is this connected to health? So for our project, we had a knowledge holders dinner and 2 youth workshops. And from all of our gatherings together, we had interviews, sharing circles, focus groups. We did a thematic analysis of all of these transcripts and all of the wisdoms that were shared by the youth participants and the knowledge holders. And we organized these themes into protective factors. These are characteristics that are associated with lowering the likelihood of a problem outcome, PTSD, for example. And then also protective pathways. And these are those key elements that support positive identity formation in ways that can promote healing, strength, wellness, and resilience in culturally nuanced ways. And all of these elements, these protective factors and these protective pathways are part of a cultural coming of age, and specifically an Indigenous coming of age that holds within it those rites of passage that teach these things to carry forward into adulthood. But then we have to ask as well, why is this so crucial for Indigenous youth? So we need to acknowledge that Indigenous youth, through no fault of their own, have been born into a society that has politicized their identity. Efforts of the Canadian government to dispossess Indigenous people from their lands often manifested as policies and practices that specifically targeted and worked to eliminate the intergenerational passage of cultural teachings. One of the most visible ripple effects of this today is the disproportionate representation of Indigenous children in the child welfare system. So this disconnection, Dr. Leroy Littlebear tells us, he's a Blackfoot scholar, he tells us that this created a fragmented worldview among Indigenous people, and one that consisted of innate Indigenous worldviews and imposed European worldviews. Now this phenomena, he calls jagged worldviews colliding, talks about how this worldview has made it particularly difficult for young people to have harmony and balance in their lives, and with that, attain that holistic wellness that is so important. We see the fallout in this in many areas of health and dis-ease in ways that are represented in a number of different health outcomes. But he also tells us with the right opportunities to become whole and balanced, young people are better able to be part of a whole network and keep their home fires burning. So this is Julene Geronimo, and she stands here at her sunrise ceremony, and this is part of her Apache coming of age. So of this ceremony, her grandfather, Joseph Geronimo, said, it will keep her strong the rest of her life, and not only that, it will keep the tribe strong. Coming of age may focus on the passage to adulthood, but it takes an entire community and it works to heal an entire community. The benefits to the one person benefits the whole. So I really want to emphasize here too that reconnecting to coming of age ceremonies and rites of passage, this is not conceptual and it's not theoretical. It's an active embodiment of one's culture. This reconnecting to coming of age teachings is what scholar Kucha Riesling-Baldi has called embodied decolonization. And she calls it this because it actively counters ways that colonialism sought to disrupt the passage of intergenerational teachings by revitalizing and celebrating those connections once more. And taking this a step further too, there's empirical evidence here as well to support the arguments for positive outcomes of having access to culture and cultural continuity. In the 1998 seminal paper by Drs. Chandler and Lalonde, they show that the more connections that youth have to cultural institutions in their communities, the fewer youth suicides were reported. So as care providers, then how can we help? I believe that the best way to support this positive action initiative is to reflect on practicing critical allyship. And this is a term that's been really put forward by Dr. Stephanie Nixon. She works out of the University of Toronto. And what that would mean in this context is to reflect on our positionality as care providers and consider how we can support Indigenous families and communities who never gave up their rights to raise their children on their lands and according to their traditions. This is going to look different for each one of us, but consider that by supporting this just a little, you also become part of this embodied decolonization because you will actively push back against some of those structures that sought to prevent Indigenous self-determination. So in closing here, I want to say a really big thank you to all of you for your time and attention, and then BC Support Unit, of course, for accepting this abstract and allowing me this space to present to you today. I hope that you've been able to come away with maybe some of your own insights into how culturally appropriate coming of age can be coordinated into your care practice, and then also why it's an important component to support our young Indigenous partners. And I know I had a number of citations in here for different studies and whatnot. If you are interested in any of these further, please send me an email here, and I'd be happy to answer any of your questions now or by email if that's better. So I think we still have a few minutes left, and I'm just going to stop sharing my screen now. Thanks, everybody.
Are there any, we do have a couple minutes if you have questions for Andrea. Or you guys can chat and follow up. Go ahead, sorry.
Thanks, Wendy, for your comment there. And I want to say too that the landscape photos, my stepdad's a photographer, and so the credit there to him. I always like to acknowledge and honor him too in everything that he shares in kind.
Okay, sounds like we're okay for now. Andrea, thank you. And our next presenters. Oh, right, look how great they are. Right on time.
You jinxed it because we couldn't get our videos going, but there we go. So hi, thank you, and thank you for those wonderful presentations. This is a nice collective group of presentations that are radically different, but hopefully all will come together at the end. So this presentation is called ED to Foundry, and I'm going to introduce the project shortly, but I just wanted to introduce myself. I'm Sky, and Jade, do you want to say hello so they know your voice?
Hi.
Want a little louder, Jade?
Hello.
There you are. Okay, perfect. I can hear. So we'll be cutting in and out in this presentation together. The purpose of this project and this study was to engage young people, families, health providers across British Columbia to enhance the experience of young people with mental illness and substance use disorders in the emergency department. So when presenting to the emergency department, and also to leverage a new opportunity with the expansion of something called Foundry, which I'll talk about shortly, to leverage that opportunity of an expansion of Foundry across the province to be able to use the emergency department as an opportunity to connect young people into youth-centered services. And pass it off to Jade.
I would say that it's a tough experience. Unfortunately, I don't think it's a very positive experience. I think there are a lot of holes in the system, and I don't think we particularly serve our youth mental health patients very well. We can do so much better in British Columbia.
So we're going to be embedding quotes from our participants in our study throughout, and just so that you know that it's not just Jade and I. This is our team, which includes Madeline White, who's one of our youth research assistants, that has been working really closely with Jade, and then a team from both emergency department and psychiatry at UBC and at Providence Health. So Dr. Schermeyers, Matthias, and Dr. Rarbeck, David Rarbeck from the Emerge. So I also want to acknowledge that we have the privilege of being able to conduct this research and present today from the unceded territory of the Coast Salish people, and we definitely acknowledge that we're guests and uninvited guests on this land, but really feel privileged to have had the opportunity to do this work and advance the health of and well-being of all British Columbians. This also want to acknowledge that this was funded by the Michael Smith Convening and Collaborating Grant. And I put it in quotes just because you'll see soon that we had to modify this project due to COVID, but we're very, very thankful that Michael Smith was flexible to allow us to do this. We also want to report that our team does not have any conflicts of interest to declare. So plan for this morning is I want to explain what the ED to Foundry project is, briefly discuss what Foundry is, what did we do, what did we find, and so what. So first, why ED to Foundry? 1 in 4 young people in British Columbia experience a mental health or substance use challenge each year. And across British Columbia and Canada, we've seen the rates of emergency department visits for young people increase by 85%, according to CIHI and local health authorities. We also have wonderful emergency department staff who are recognizing this as well on the front line and saying, this is great that they're coming, but we really haven't received significant training about how to support young people with mental illness and substance use disorders, or even supporting their family. And what we also learned was that young people and families have rarely been involved in any co-design of best practice guidelines or pathways of care in the emergency department. And in 2015 and 16, British Columbia really invested significantly in a new youth-centered model of care called Foundry. And that model of care really created an opportunity for us to work together with Foundry, the emergency department, and young people across the province to find out how we could best enhance the experience of young people accessing the emergency department, and how we could best connect those who are appropriate for discharge from the emergency department, how we could actually connect them into this new youth-centered service. So what is Foundry? Foundry is an integrated health center for young people aged 12 to 24-year-olds. They provide primary care, sexual health counseling, mental health, substance use support, and peer support, and social services all in one easy to access location. And the goal is that young people can walk into these youth-friendly services, and this is where wellness takes shape. The current landscape of Foundries across British Columbia in green are centers that are open. So there are currently 10 centers open and 9 in development. This is what the profile has looked like with the 8 centers pretty much operating. The 9th has just come on board and 10th coming on board right now. But it is definitely serving a need, and a lot of young people are coming in, and they're not coming in just once, they're coming in for multiple visits and accessing multiple services within those visits. And this is just a bar graph to describe what is where young people are seeking services. If you want to know more about Foundry, please go to foundrybc.ca. So the purpose of this project was we were anecdotally and as clinicians really seeing a lot of young people starting to show up to the emergency department. And the question was whether or not this was actually, you know, the best experience for them. And we were hearing from a lot of young people, not all young people, but a lot of young people, that it was a pretty tough experience for them. And that after leaving the emergency department, being connected into services was even tougher, and that the pressure for the young person and their family was often put on them to navigate the healthcare system. And I know this is certainly not unique to any health condition, but this was certainly quite an important area for young people to address. And so the real goal of this emergency department to Foundry initiative was to understand the experiences from young people, families, emergency department providers, and Foundry providers about what the current experience is for young people, but also what could the experience be. So we really made this a strength-focused study to allow us to dream up new opportunities. So our plan A was to have a nice, beautiful day of convening and collaborating as per the Michael Smith grant on April 9th in Vancouver. Of course, this happened and everybody doesn't need to know more about that. But what we ended up doing was it actually created an incredible opportunity for us to be much more inclusive. And we ended up doing one-to-one interviews with young people, families, ED providers, and Foundry providers. And we've reached saturation in each of our areas except for youth, and we'll talk about that a little bit in the limitations section. So we're presenting to you our preliminary findings on this, but I do want to highlight that maybe one of the better things of COVID that allowed us to do was to actually reach many more young people across the province and other stakeholders across the province, and to use Zoom technology as a very accessible way in which they could participate rather than getting on a plane and coming down to Vancouver as the original plan was. So this is in brief. What we did is we asked them both what the current experience is and what the dream experience could be like. What does the current experience look like for a young person accessing the emergency department? And what's that ideal dream experience? And we did that in the same way of trying to understand also how young people were being assessed in the Emerge, how they were being connected into the community, and how both emergency departments and Foundries were working together to enhance that experience. So here's what we found. We use a thematic analysis to look at common themes between the groups and also within themes in terms of the individual stakeholders for whom we engaged. So theme one was things have to change, or one day I will die in a system. I died trying in a system that never let me try. And so collectively across all four stakeholders groups, what we heard was that the emergency department was not youth-friendly, was highly stigmatizing, and not designed for people who were reporting of mental health and substance use crises. And from the strength-focused perspective, though, the theme two was it can be better if you include youth, families, ED providers together in the planning. And so this is clearly preaching to this choir at this conference, but what young people came up with was this incredible set of solutions, but so did families and so did ED providers and providers who are actually providing service in the community. So, you know, in terms of really, we probably could spend an entire presentation on this, just this theme, but in terms of looking at the environment and setting up the environment and setting up the care pathways to make sure that they were youth-friendly, that they prioritized young people, that things like peer support could be available 24/7, and that young people were placed in rooms or offered rooms and locations that would enhance their care experience and make them trust the system. One thing too that was brought up in theme two was having young people and families being involved in the education of ED providers. And this actually came mostly from emergency department providers who are saying, we want to know, we want to learn from youth and families, and we want to have regular co-learning opportunities so that we can enhance this experience, because ED providers really reported that their training covers a bit of this, but really doesn't cover or focus specifically on young people and families who present with mental health and substance use disorders. And this was a certain opportunity for future co-creation.
It is reasonably negative and disjointed. The presentation and experience for a youth is out of desperation and sort of being unable to find or access other resources. Accessing a service with a medical model that is primarily designed for quick access and discharge. It doesn't really provide much for engagement connection. It feels like it is designed to get me out of sight, and as quickly as possible.
We also had findings about the assessment process, and that, the idea that if you present with a broken ankle, there's a pretty similar process of assessment and care. And for what we found across all stakeholder groups, when we were asking in people and the other stakeholders about what the assessment process is, the common theme was, I don't know. Some Emerge docs did report that they had some tools at their resources, and please feel free after this to read some of the quotes of this. But overwhelmingly what we heard was that, and I'm using a quote from one of our participants, Emerge docs are starving for data that they can feel is useful and patient-centered. And so they want to be it, but they don't feel like there are the tools that are necessarily youth and family-centered that they can provide standardized assessments every time.
I would just appreciate the phone call and say, I'm here, sorry, I'm taking care of it, come when you can, right? I know I've been in and out enough to know that if they're taking away my child by an ambulance, I can actually sit and have a cup of tea before I go, because I know that they're going to be stuck in a hallway in restraints for a long time, and I'm gonna have to come in and have to have the energy to navigate the system and advocate for my child.
So theme 2 had a lot to do with system navigation, and specifically we called it, or it was called by a lot of participants, as I only have to tell my story once. And the ideal process that was described by all stakeholders that we interviewed was that young people are only assessed once. The time in the emergency department is short as possible, so that they're either triaged up into inpatient if that's where that needs to go, or they're quickly connected to community resources for follow-up. Also that the assessments that we would need for strength-focused, developmentally appropriate, and culturally sensitive assessments. And young people repeatedly described that they had to be assessed up to 10 times before they were finally connected in to the person who would develop their care plan with them. We also described that data are empowering for young people, service providers, and family, that an assessment would actually give some information and inform a plan, rather than feeling like, for a participant said, you're being assessed to death. Theme 4 is that we had the same way of communicating, and prioritizing the use of preferred pronouns, and the preferred name was a perfect example of something very tangible that young people described, that they want to come in, they want to feel heard, and want to feel that they are welcome in the emergency department. But emergency providers also felt that there was also a need for common communication between health providers and between them and the community, and that they need some sense of not only having a common electronic medical record and way of sharing data on that young person, but clear communication about how do you actually even call a community center, how do you actually connect a young person to the community resources, in this case, Foundry, from the emergency department. There was a lot of lack of information there. But one thing that really came out was that this is community specific. So there are really, some of our smaller communities talked about the urbanization of care pathways, and we have to be much more community specific.
In an ideal situation, I would see them right from triage. Take them to a quiet area, interview them with some standard set of youth-centered questions, plus or minus interviewing the parents or guardians that come in with them, and even connect them immediately to resources that are available like Foundry. Basically, there is no systematic way of assessing young people, and there are huge barriers and consequences to this. ED physicians have to know about what to ask and where to send people. We know very little. We are starved for this information.
So theme 5, I'm going to just briefly say, and then you can read this on your own, is not another pamphlet. Across the board, no one wanted to be receiving pamphlets or giving out pamphlets. They wanted a really clear way of connecting people in.
If we could have 24 access to somebody coming in to help create that bridge to the emergency department, that would be great, as is our struggle with substance and mental health presentations. Having timely access to that connection at appropriate times would be great, rather than a patient and family consistently needing to seek out the resources and basically try to navigate the system on their own.
So the last one is we need to work together. We'll emphasize this with a quote.
I am ridiculously proud of my team. They are special. The system can be ridiculous, can be shitty, can be uncaring, all of those things. There are people in the system that actually do give a shit. There are people in the system who are actually trying to do good work.
So collectively, our data, just to summarize, talked about the importance of bringing together a youth-centered emergency department experience through co-learning opportunities and having people, all of these stakeholders together. Also talked about the importance of developing a youth-centered assessment and care pathways, and this is areas of focus that we'll be looking at in the future. Raising awareness of Foundry in the communities is something that was brought up a lot by the emergency department visits, and having that awareness ideally raised by young people and families and a co-learning opportunity there. And also working forward and making sure that these care pathways are also including government and people who make policies and decisions so that we could have these rapidly put into practice. Our last, I'm going to skip to this in our last slide, but we do have a call for young people. We need a few more young people to finish up this study, ideally in the near future, but we will end our presentation with a quote.
I know that it can get really frustrating when you see the same people over and over showing up to the ER, but I always really hope people can see the bravery and the courage in that. They're just trying to keep themselves alive. And whatever we attempted before didn't work for whatever reason. And I think some people can get weird perspectives about that versus seeing it for what it is.
So thank you. And if you have more questions, please feel free to send me an email or tweet me or tweet Jade, and we'd be happy to answer more. Thank you.
Thank you. Great presentations today. So we are out of time for this session. Thank you so much, our presenters, for sharing their work. The poster session starts now at 11:30, and the plenary session starts at 1. So we hope you're enjoying the conference, and we'll talk to you again soon. Thank you.